All right, here's your algorithm. This is on radiopedia.org. It's an excellent, excellent website, just in case you want something to take home with you to refer back to. A, B, C, D, E. All right? So let's start from the beginning. Anatomy and alignment. Knowing your anatomy is power. Am I right? And it's not just with orthopedics. It's with everything. If you know what bone is, then you can likely figure out what the problem is. Okay? And then alignment. Those are kind of the two biggest things, and I'm glad it starts with A, because that's the first thing you should look at. Anatomy and alignment. B, the bone. Oh, duh. All these orthopods running around. Broken bone, fix it. I'm sure you guys have seen the YouTube memes. Like, it's not hard to make fun of orthopods. But x-rays are meant to look at bones, okay? As we go through this algorithm, you'll start to understand that it's really not just about the bone. But that's what your eyes should go to first. C, cartilage. That is the structure that encompasses the end of the bones, okay? D, deformity and density. We'll go over that here shortly. That's a little bit harder to explain just with words. It's a lot easier to explain with pictures. And then E, everything else, right? Sometimes the everything encompasses A, B, C, D, right? The density changes can kind of trigger what you're looking at. Is that a tumor? Is that fluid? Is it a hematoma, right? So it's not just the bone. That's essentially what this algorithm is telling us, okay? If there's one thing you take away from today, an x-ray is not just the bone, all right? Okay, radiographic principles. You always, always, always want to have a methodical approach. If you go through something the same way each time, you won't miss anything. I'm sure you tell your kids that. At least I do. You wake up in the morning and you brush your teeth. It's very simple. But somehow they seem to forget that because they don't follow the algorithm, okay? Methodical approach. Then you have your non-negotiables, all right? And a little bit of the non-negotiables feeds into the third bullet of appropriate views. If you're in the ER and you're the APP on service and you have a patient that comes in and you're calling, let's say, the orthopedic person that's on call, what's that orthopedic person going to ask when you call? Are there x-rays? What type of x-rays did you get? And what do you see? Okay? Whenever you're trying to diagnose something, you always want to make sure you have the appropriate views. Let's take a step back, and let's just say it's not even about orthopedics. Let's say you're just trying to diagnose a UTI. Of course, that's a clinical presentation, but what helps you with your diagnosis? A urinalysis, yes, a physical exam, etc. So the same thing goes with radiographs. You have to get the appropriate x-rays. And then finally, like I said, it's not just the bone. All right? So, plain radiographs. Super cheap, way cheaper than a CT and an MRI. It gives you as much information that you could probably need to get some type of working diagnosis, right? It may not give you your final diagnosis, but it's going to get you to a point where you can actually start to implement a treatment plan. Okay? So number one, cost effective. Number two, minimal delay. It's pretty easy to kind of wheel a C-arm or wheel any sort of x-ray machine into a room and get a chest x-ray, get a leg x-ray, whatever it is. Alright? So you're not waiting. I'll tell you, at our institution, to get an MRI is almost like an act of Congress. I'm sure a lot of you experience the same thing. So if you're trying to help your patient, that's what we're trying to do as providers, get an x-ray. It's simple. And there's so much information, right? Again, your algorithm, A, B, C, D, E. Okay? Okay, so what's our approach? Always, always, always get more than one view. All right? I cannot overstate that enough. You will miss a fracture. You will miss a diagnosis if you rely on one view. You want to know how I know that? Because I did it. Right? I missed a distal radius fracture because all I got was one view. Patient comes back to see me 2 weeks later, completely collapsed. Fracture looks awful, could have prevented a surgery, and now here we are. We're taking the patient to the operating room on Friday. Always get another view. No one will ever fault you for getting more views, ever. Obtain radiographs of joint above and below. Okay, so let's talk a little bit about this. You're like, what are you talking about? Like someone comes in, they're complaining of wrist pain. Why the heck am I going to get an x-ray of their elbow, right? Exactly. 3 views anytime you can. So let's talk a little bit about why you get the joint above and below. I'm going to give you an example. Patient comes in complaining of knee pain, okay? They fell while walking on a curb, kind of twisted their knee, and then started walking a little wonky, all right? They come to the office, you get an x-ray of their knee, right? They're complaining of knee pain. Pretty normal, not terrible. You're doing your exam, you look at the x-ray, say, hey, like this doesn't look that bad. What else is bothering you? Actually, nothing. My ankle kind of hurts here and there, but not terrible. So you send the patient out. Patient comes back a week later because they're continuing to have pain. Now it is in their ankle. They have a dislocation of their ankle of the syndesmosis, where the syndesmosis is now wide. Okay? We call that a Mason-Ove injury, where you have an injury either at the knee or the ankle, and the energy from the trauma has gone all the way up into the knee or the ankle, vice versa. That's bad, right? And that hurts. And another instance of where you probably could have avoided surgery and proceeded with conservative management, but because we didn't get appropriate views or the correct joint above and below, we missed the diagnosis. Now, a lot of this comes with some nuance, right? If someone comes in with, let's say, neck pain, you're not necessarily going to x-ray their entire back, right? There is a little bit of this that you do have to listen to the patient of what they're telling you. In the previous example, the patient told you that the ankle was hurting a little bit, right? Listen to them. They're telling you what's wrong with them, okay? And then evaluate soft tissues and density changes. This feeds a little bit into that algorithm piece like we talked about earlier. I learned this from a pelvic and acetabular surgeon in Houston. He is the best pelvic and acetabular surgeon in the world. And if there's one thing I remember of him teaching us was that. Look at the soft tissues. You can tell if someone's bleeding into their abdomen. You can tell if someone has a tumor. You can tell all types of things, right? If they have a rotator cuff tear, you can diagnose that without an MRI if you're looking at the right things on x-ray. Okay? All right, so here we go. Who wants to take a stab at this as far as describing what you see? Displaced? Okay, who else? Just yell it out. Come on now. I'm going to start calling on y'all. Ulnar, okay? Okay, let me help you out. This is a normal x-ray. The purpose of throwing this up there is multifaceted, okay? When you're looking at an x-ray and you have to relay back to your attending or to whoever you're calling consult for, you have to be able to explain the x-ray in a way where they have no screen in front of them and they can understand exactly what you're saying. Okay? So let me show you how you do it. This is an AP unilateral of a skeletally mature individual. Okay? That's the first thing. How do I know that it's a skeletally mature individual? The physes. Everybody know what a growth plate is? The physes is fused. So you know that they're not a child. They're skeletally mature. There's no more growth happening. Okay? AP and lateral of a skeletally mature individual. Okay?